There is actually not much of a difference in the rationale of doing adult and pediatric segmental spinal. So I assume and presume that everyone is knowing what is segmental spinal. So I will not go into details of this. But because of some developmental, anatomical, and some physiological factors that make slight difference in neonates, infants, and small children, and makes it a little difficult and less acceptable in this category of patients. Otherwise, it is almost similar to your adult this thing. I'll just go through anatomical physiological differences initially between the adult and pediatric patients. And one thing, we always need some procedural sedation in these kind of patients, especially small kids. And DexKet, which is very good for pediatric patients. I can't imagine my segmental spinal without the DexKet. So I'll share some pearls about DexKet also in this presentation, just to make it more acceptable, and about the drugs, doses, and the technique about segmental spinal pediatric patients, and some short videos. So pediatric spinal, segmental spinal, is it possible? The pediatric spinal anesthesia was first described in 1909, but did not become the part of routine practice until 1980s, when regional anesthesia increased in popularity. Even at that time, it was only used to avoid the general anesthesia, especially in ex-premature infants up to 60 weeks post-conception. In those patients, there is a high chance of post-op apnea, so it was used mostly for below umbilical surgeries. Pediatric thoracic segmental spinal is still in infancy, but thoracic epidural anesthesia is commonly practiced. But yes, it is possible with due precautions and sound knowledge about other aspects of pediatric anesthesia. Now, just to brush up our knowledge, the differences, everyone knows the differences between adult and pediatric patients. What are the anatomical differences? Just to have a short revision, I'll cover it. In adults, the conus medullaris ends at L1. In premature babies, it is almost at L4. In newborns, it is L3. The dural sac is around S4 in newborns. Around 1 year of age, it is S2. And dural sac ends at S1 in adults. The intercostal line, which we take as a landmark for giving lumbar spinal, also holds true, even though there is differences between the conus medullaris and all, just because the sacrum is slightly capillarly placed. And that's why the intercostal line crosses the spinal axis at L5-S1 level in neonates and infants up to 1 year of age, and L4, L5 levels in older children. So you can take the same intercostal line as a landmark for counting the spaces. There is absent thoracic kyphosis in neonates and infants. That's why you should avoid lifting the legs, especially when you're using hyperbaric drugs immediately after giving spinals. There are chances of high spinal or total spinal in such kind of patients. The CSF volume in children is different in different age groups. In neonates, it is almost 10 ml per kg. Infants less than 15 kg, it is 4 ml per kg. Young children around 3 ml per kg. And adolescent and adults, it is around 2 ml per kg. And also there is difference between the total volume of CSF in the spinal canal between adults and pediatric patients. In pediatric patients, almost 50% of the total volume is in the spinal canal, while in adults, it is only 33% of the total volume. Highly vascular pyometer is there, combined with a greater cardiac output, leads to faster reabsorption of the local anesthetic drugs in pediatric patients. Myelin sheath is not fully developed in infants and small children, resulting in faster onset and offset of spinal anesthesia as compared to adults. You need to have some additives to prolong the duration of spinal anesthesia in such patients. About the spine and ligaments, the laminae are cartilaginous in neonates and infants. So we have to be cautious during a pyramidine approach in these kind of patients. There are chances that you may just damage the cartilaginous laminae with undue force. So it's better to have a midline approach in these patients. Ligaments are less dense. So LOR, loss of resistance, may not be well appreciated in these patients. About the physiological aspects, there's immature sympathetic system and complex reduction in the vagal activity. That leads to less vasoplegia. Also, there is small venous capitance in the lower limbs. All these lead to less cardiovascular changes related to spinal anesthesia in children below 5 years of age. Older children, more than 8 years, it is almost similar to adults. Sympathetic block may induce bradycardia and hypotension. About the respiratory system, high levels of the block reduce the outward motion of the lower rib cage. So there can be some paradoxical respiratory movements, but diaphragm compensates for the loss of rib cage movements contribution. Now coming to the feasibility of thoracic segmental spinal anesthesia in children. This is a MRI, which shows this was done in patients aged 0 to 13 years. Similar explanation as was done in adults. The mean diameter of the spinal cord distance was 4.52 millimeters at T2, 5.61 millimeter at T5, 4.6 at T10, and the distance corrected by the angle was quite high. It was 6.07 millimeter at T2, 8.18 millimeter at T5, and 6.57 at T10 levels. That justifies your giving segmental spinal in pediatric patients also. Some advantages were routine spinal or general anesthesia. Generally, spinal anesthesia for pediatric patients is indicated only for below umbilical surgeries. But here, the upper abdominal and superficial thoracic surgeries are possible under segmental spinal, just like adults. You require just half the dose than that you require for lumbar-spinal to achieve the higher levels of the block. There's early recovery voiding and less post-op nausea and vomiting in these patients. Airway-related issues are avoided in pediatric patients. As we all know, you can have a lot of airway-related issues, bronchospasm, laryngospasm, and whatnot. And at times, patient you can be in trouble related to these airway issues. So there are less chances of post-op apnea in premature infants. This is most indicated technique for such kind of patients, especially useful in patients with respiratory issues. Indications and different modes of segmental spinal, all intra-abdominal surgeries, all, and different kinds of surgeries, open, lap, upper, lower, major, minor. They can be done under segmental spinal, superficial thoracic, even breast surgeries are possible. There are three different modes. Actually, it can be done for short duration surgeries in the single shot segmental spinal, can be combined with epidurals. The third option, in very complex surgeries, there are reports of it being used for more complex, even cardiac surgeries in combination with general anesthesia. You can combine it with GA in very small kits if required. About the spinal needles, there are a variety of spinal needles available for pediatric patients. You can use either quick or pencil point needles, 25 to 30 millimeters for infants, 50 millimeters for small children, and for adults and adolescents, your routine adult spinal needle you can use. I usually use my adult 27 gauge needle in all patients because most of the time the pediatric needles are not available. Now, for every kit, you need some procedural sedation analgesia. So I'll cover some part of this procedural sedation analgesia before proceeding for segmental spinal. And emergency resuscitation equipments appropriate for pediatric patients should be available. SOAP-ME is a useful mnemonic for this. S stands for suction catheters apparatus, O for oxygen supply delivery equipments, A for airway equipments, all types of airway equipments, P for positive pressure delivery system, M for monitors, and E for emergency cart with alternate airway. You should be ready with all this before proceeding for any procedural sedation analgesia in kits. Now coming to DexKet, a combination of dexmedetomidine and ketamine makes pharmacological sense. They balance the hemodynamic and adverse effects of each other. Dexmed prevents the tachycardia, hypertension, salivation, and emergence from ketamine, and ketamine prevents the bradycardia and hypotension caused by Dexmed. The ketamine also speeds the slow onset of Dexmed. It speeds the onset of sedation. The most effective regime is bolus dose of 0.5 mcg per kg of Dexmed mixed with 1 milligram per kg of ketamine, diluted slightly, I dilute it up to 5 ml, and then give slow boluses titrating to target sedation. Then maintenance dose, you can just use half the initial dose according to need in a short boluses, or if you have that infusion pumps, you can use those. Co-administration can be intramuscular buccal, but intranasal is the preferred route when IV is not feasible or not desired. Lack of recovery-related agitation is very significant in DexKet. Now, ultrasound in pediatric patients is very useful because it shows very nicely before there is ossification in less than 3 months of old kids. You can use high-frequency linear array transducers for scanning these patient position. You can do it in lateral or prone positions. For small kids, you can even use transspinous approach, or in older kids, parasagittal spinous approach can be used. Non-ossified posterior elements of the vertebral column in the first 3 months of life provide an excellent acoustic window for spinal USG. You can clearly see even the spinal canal, ependymal canal, the posterior complex, ligamentum flavum, and dorsal dura, anterior dura. Everything can be very clearly seen. Even the conus medullaris, you can always see this in less than 3 months old children because there is less ossified posterior elements of vertebral column. Even the pulsatility of the spinal calor can be seen very nicely. If the spinal cord is 3/3, it will be absent here. A USG thoracic spine, as I have already told, you can see very nicely the posterior complex, anterior complex. You can see the direction of the dural space nicely. You can do even USG guided thoracic spinals in kits if you have those facilities available. Then you can have about the landmarks for giving you a segmental spine. You can start from L5S1 level, then you can try the 12th rib and go upwards, and thickle sac ending at S2. You can see that Ultrasound can also be helpful for detecting the hematoma. If you think you have caused some trauma to the cord or some epidural space during your performance of the spinal, you can immediately see with ultrasound. You can nicely see the evaluation of epidural hematoma after lumbar puncture. You can see here this picture clearly. It is very nicely seen in these small kits. Now, position of the patient for viewing spinal, you can use any position, lateral or sitting. But lateral position is usually preferred when some procedural sedation is given to these kits. But whatever position you use should avoid flexion of the neck to avoid airway issues. Drugs and additives, either isobaric or hyperbaric, bupivacaine, levobupivacaine, or ropivacaine can be used. Either 0.5% or even 0.25% works very nicely in small kits because there is less myelination of the cord. So for superficial surgeries, you can use your lower concentration of the drugs. Additives, there are a number of additives available, and many people are using even opioids and all. But I usually prefer the additives which will not cause post-op nausea, vomiting, and respiratory depression. So fentanyl for short duration surgeries in the dose range of 0.5 mcg per kg. Dexmed is a very good additive. Off-label, it is very useful to prolong the duration of analgesia and spinal anesthesia. Dexmed in the range of 2 to 5 mcg can be used. Ketamine, so usually not available in the preservative-free form. It can be used. Clonidine is a very good additive. 1 mcg per kg you can use when you don't have Dexmed. This is the chart which I have prepared for doses of ropivacaine for lumbar spinal as well as for segmental spinal. In the upper part, showing for lumbar spinal, the doses are mentioned in milligram per kg, ml per kg, and there is a simple formula about for 2 to 12 years of age in years divided by a fixed number, that is 5, equal to ml of the drug. So for neonates less than 5 kg, it is 1 milligram per kg. Infants 5 to 15 kg, it is 0.4 milligram per kg. Above 15 kg up to 2 to 12 years, it is 0.3 milligram per kg. In ml per kg, this is 0.2 ml per kg for neonates less than 5 kg. 5 to 15 kg, it is 0.08 ml per kg. And for children's 2 to 12 years, above 15 kg, it is 0.06 ml per kg. And fixed dose formula for lumbar spinal is age in years divided by 5, as I already told you. And for segmental spinal, this is the formula I have created. I labeled it as a Neuraxial Anesthesia Development Society modified scale for segmental spinal. And the formula goes for neonates and infants in milligram per kg and ml per kg. It is just half the dose then that is used for lumbar spinal. And for children's up to 2 to 12 years, I have some fixed formula in ml per kg, and I have divided it into 3 groups. For 2 to 4 years, age in years divided by 6. For 5 to 8 years, it is age in years divided by 7. And for 9 to 12 years, it is age in years divided by 8, equal to ml of the drug. So this is a simple formula. You can keep this in mind for giving spinal. You can vary the doses and additives according to your need. Now I'll give some examples how to calculate the dose according to the milligram per kg for lumbar spinal and for segmental spinal. Suppose there is a 3-year-old child, weight is 16 kg. So for lumbar spinal, according to milligram per kg is 16 into 0.3 equal to 4.8 milligrams. That is 0.96 ml. For segmental spinal, we use 3 by 6 equal to ml. That is 0.5 ml. For 10-year-old, 32 kg, for lumbar spinal, it will be 32 into 0.3 equal to 9.6 milligrams or 1.92 ml. For segmental spinal, it will be 10 upon 8 is equal to 1.25 ml. These are dose ranges supposed to be used for short to mid duration surgeries or abdominal laparoscopic surgeries when spinal is given at around T10. Dose of local anesthetic site of injection can be varied according to need. Now the technique of TS, thoracic segmental spinal anesthesia for neonates and infants, a midline approach is preferred, as I already told you. For older children, you can use either midline paramedian approach. If application of IMLA is not done, you need to apply IMLA just 30-40 minutes before. Then local infiltration before spinal is usually must after giving DexKet sedation. Help of ultrasound in case of difficult spinal deformities, you can take help. Assessment of the levels after spinal in infants, as we routinely do for older kids, it's not difficult. You can do as we do for adult patients. For neonates and sedated kids, transcutaneous electrical stimulation is best reproducible method. Prerequisites for successful use of TSSA in pediatric patients. Before embarking onto this pediatric segmental spinal, you need to be well versed with the other aspects of pediatric anesthesia. Indication of segmental spinal needs to match the surgical needs of the patient. All backup plan and equipments for handling emergency airway situations should be available. Hypoxia, hypothermia, hypotension, hypoperfusion should all be avoided. Proper explanation and consent is must. You should always provide some multimodal analgesia for post-op analgesia. Either you can use some interfacial plane blocks according to surgery, tab block, rectal sheath block, erectospinal plane block, or LA at the port site for laparoscopic surgeries. You can give IV paracetamol, diclofenac, dexamethasone, or there are suppositories available of paracetamol, diclofenac, tramadol, etc. You can use those for post-op analgesia. Now, something about do's and don'ts. In the do's, you need to do a complete comprehensive pre-anesthetic evaluation of the kit. What are the developmental anomalies, if there are any congenital associated defects or something, and any upper respiratory infections or other anomalies. Then informed consent. Proper patient positioning, whatever position you want, avoid the flexion of the head. Proper use of the tools. If you have available ultrasound, you can take the help. Spinal needles according to the age group. Precise dosage administration. It can vary a little bit, but should be according to your surgeon, surgery, and the duration of surgery. Then continuous monitoring. You always need to monitor the patient continuously, even after spinal, adequate multimodal analgesia for post-op care, and always have a backup plan. In the don'ts, don't use this technique unless you are familiar with other aspects of pediatric general and regional anesthesia. Avoid rough handling, be gentle, and proceed millimeter by millimeter. Avoid higher doses of LA at higher spaces. Just like in adult patients, the dictum is higher the level, higher the space you use, lower the doses. Don't use multiple and excessive dose of additives unless you are well versed with the behavior. Just use a simple additives and in a limited doses. Don't use excessive sedation to avoid airway issues. Excessive sedation can create airway issues, so better not to use excessive sedation. For that matter, I have told you the DexKet is the best sedation which maintains the tone and integrity of the airways. Don't use this for neck and upper extremity surgeries. Though it is possible to do even thyroid or upper extremity surgeries under segmental spinal, we usually don't advise this just because there are more simple and less invasive blocks available for such technique. Now I'll show some videos. This is very old, some 12-15 years back. 2 years congenital hernia. It was done under isoveric DexKet plus spinal. This is 2.5 years hysterectomy with pre-procedural dilatation for phimosis. DexKet plus spinal L1 2. Just 1 ml of isoveric levobupivacaine. You can see after DexKet, even O2 supplement is not required most of the time. Actually, I don't have my old videos of special cases like I did some laparoscopic cholecystectomy in a patient with this 6 years old. So, and some neonatal surgeries which done previously, but unfortunately I don't have the videos. This was a 8-year-old 26 kg lap chole. It was recently done some 2-3 months back. 26 kg lap chole, 1.3 ml plus fentanyl 20 mg at T11-12. You can see the child is comfortable. At the end of surgery, he is conscious, he is moving his limbs. Then this is 6 years old acute appendicitis, just 1.1 ml at 20 mcg fentanyl. I use 27 gauge adult needle for this. Need to be gentle while performing spinal in these cases. You just go millimeter by millimeter. No harm in taking some time. You remove the stylet at a very loss of resistance. I usually use lateral position for all my spinals, kids or adults. A little DexKet was given, but the child is conscious, comfortable. You can see this was a simple acute appendicitis. At the end of surgery, you can see this was 12 years old female for twisted ovarian cyst. According to formula 12/8, 1.5 ml plus 20 mcg of fentanyl. First local infiltration was done. She was not given any sedation before spinal because she was a cooperative child. Just a local infiltration and then spinal with 27 gauge needle. The levels being tested, she had adequate levels up to T2, T3. With ETCO2 monitoring. at the time of closure, and the patient is shifting herself at the end of surgery. This is 8 years old perforated appendix. In emergency, it was done. He was febrile. Segmental spinal T 11-12, 1.5 ml with 20 mcg fentanyl. This is during surgery. He is conscious, comfortable. And see perforated appendix. At the end of surgery, lifting his legs completely. This was 13 years old, 34 kg bicoordinate uterus with rudimentary right cornu. So 1.5 ml isobaric bupivacaine was given because surgery expected to have some longer duration and some relaxation was needed. So isobaric bupivacaine with 5 mcg of Dexmed was used in this patient for rudimentary horn excision. And see, there was a right horn which was quite large. And after that, hysteroscopic confirmation. The surgery went on for almost 2 hours at the end of surgery. This is just to show the effectiveness of DexKet. You see all the monitoring, even ETCO2 is being monitored. Now the utility of DexKet in pediatric patients. I have used DexKet for almost anything, right from IOL, pediatric IOL, lacrimal probing, for foreign body removals. I removed almost 30-40 foreign bodies for upper GI in pediatric patients for Ludwig's angina and all sorts of, just to cover up the DexKet. And thank you very much for patient listening.